and all of those kind of things, and it's just a little bit more expensive. But if you remove it after the 2 years, it's still rapidly reversible. It's not the most cost effective.
It's over here.
So potentially it's kind of a correct answer, but not really.
It's dirty, sorry.
Did you guys already look at all the questions?
It's good.
So on that question, we were discussing it, and we couldn't eliminate the last one, the one with the 2 year versus, we were assuming that she was testing us on the reversibility, but based on that logic, but we couldn't like talk it out, like why wouldn't you give it that way?
So essentially, why wouldn't you give it is mostly it's not a cost-effective option. So it's still gonna be, it's very effective.
Work though, right?
It's still gonna work. But if you're trying to look out for like the best interest of your patient, one of the things you're gonna also look at is cost. So is this gonna be, is it effective? Yes. If your patient's willing to pay the extra money, that's fine too. But that's the main reason why that isn't the option that I would pick. It's not like it's technically wrong, like you'd never give it, but it's which one is more preferred in that situation.
There are some insurances that do cover IUDs, and that's not a contraindication or any reason to not get it, so we're left like a little bit in the gray area with this one because we couldn't eliminate A or D.
Well, and probably a better way for me to word the question would be on the exam, which of these patients would be the best, would be the best candidate for this? Because you guys are thinking the right way. Yes, you could use this potentially, but the reason why I wouldn't pick that as the answer is it's not cost effective for that time frame. If she wants to get pregnant, doesn't want to get pregnant for 5 years or 10 years, then it would be a better option. But you guys are thinking the right way, so that's good.
I like that too. I like that example because I think that one of the things that we teach you guys, even as you're getting into the 3 year, is that every drug will work. So every antidepressant will be equally effective, but that doesn't mean that you give them every antidepressant or any antidepressant. And it does come back sometimes to cost. Sometimes I personally will include cost information in the case to help rule that out. But I think that's one of the key factors is that gray is going to be the color of your profession. And so I want to let you know that this is the kind of stuff that you will see more of as you move forward. But that's exactly the right mindset, is that a lot of them will work, but what will be the best one for that individual? And then we're going to do a lot of that with all of you guys as you move into the other patient care series. But that's a good example of that.
So when you say best one, we have to take into account contraindications, the disease state, cost, and patient specificity to answer that question. That's how you're going to answer this.
Yes. And that's kind of going to be the way that it's going to be kind of moving forwards for you guys, just like what Dr. Fuentes said. For most of the stuff for you guys, I really didn't talk about cost very much. For the IUDs, I did talk about it typically like not being cost effective to use it for a very short term. So that's probably the only piece of cost I'm really going to get into with you guys. But there's certain disease states and certain things where you'll really know that certain therapies are like much more expensive than others. And then you'll definitely factor that in when you're looking at things. Not so much for this first exam, but you pretty much said, what do pharmacists do? Yes, we do that. So I like the way you're thinking. Did you have a question?
Oh, I was thinking like them too, but like the way I read D is that she wants to have a baby within the next 2 years. So that's how I read it. It didn't say like in 2 years, within the 2 years. So based on that, IUD does make sense.
Exactly. So it's reversible, but it's not really cost effective, and the fact that she's wanting to get pregnant sooner. So maybe she does want to delay. She doesn't want to get pregnant, in the next 5 months because she's finishing pharmacy school or doing whatever. but she knows, okay, well, after pharmacy school, I'm gonna take a year off, and that's when I wanna get pregnant, then I would not choose that as one of my options. So gastric bypass, that's kind of a flag for us, right? So what'd you guys come up with for this one? Your team can help you. What, how about this? I'll make it a little bit easier. Tell us one you wouldn't recommend out of those options. So I heard your phone a friend saying they wouldn't recommend this one, right? Probably because she has that gastric bypass, right? So what's another one you wouldn't recommend because of the gastric bypass?
IUD. The IUD. The copper one.
Hey.
Just
Blood pressure was, if blood pressure is very, very high, use progesterone.
So the gastric bypass means she's not gonna absorb her progestin only one, just like she's not gonna absorb the combined oral, right? So that gastric bypass is kind of a key piece to that. And then copper IUD is looking a lot better in this situation, right? Because it's not gonna have, we're avoiding the GI issue. So that's the direction I would go on that one.
so which one's the answer?
Why is C wrong?
So C, I think you could probably potentially use both of these, right? So when I'm looking at it, my quick initial thought is I could use both injectable medroxyprogesterone and the copper IUD. But he's looking at his mech because that's why we have mechs. And he's saying the mech says, what does the mech say? 3 for injection. So that's why the copper IUD looks better. Exactly.
So on the exam, are you going to be giving us the MET like on a paper, or is it going to be associated with certain questions?
My goal is to do it as an exam level attachment, so you can see it like wherever you're at.
Okay, so it's not just gonna be like associated with question 5 or something?
Exactly. The only ones that are probably gonna be associated with the question are going to be like the questionnaire, because it's gonna be filled out for a specific patient, kind of thing. Does that make sense to you guys? So for this one, let's select one, and we can potentially say why some of them are incorrect if you're not sure which one. So E, I think I heard it here. They're like over here. Okay, so tell us why the other ones are incorrect.
So if the patient is 35 plus and she smokes 15 cigarettes, then it's contraindicated. Second, if she has present breast cancer, then it's contraindicated. Third, she can take right away, but she needs to use backup method. Fourth, if she starts Sunday after menses, she needs to use backup method. And the last one is correct. That's this first day method where you start on first day after menses and you don't need backup.
I agree.
That's so cool.
Good job. So I told you guys I'm gonna have a patch question. I'm not gonna probably do a select all that applied as it, but I wanted you guys to get a little bit of practice working through the algorithm. Do you guys feel pretty comfortable with the algorithm? Or You haven't chose one for this yet? We're thinking, hey, he's supposed to have that as like an attachment, right? So I'm gonna just go and look. That's what I would do.
You make a hair appointment? Is that what you said?
Class.
Cutting and dye?
Yeah. But not now.
Okay, so let's walk through this one. And I see you got your chart out. Can you walk us through the chart?
All right, so it says that the patch has been off for 36 hours. So then in the chart, it says the second box will say delayed application or detachment greater than 24 hours. And then it says it has been 18 days since her last period began. So then you'll look at so then it'll say during week 2 or 3. So then that's where you'll fall under. And then the detachment, less than 72 hours, less than 3 days. So then you'll go down and say apply a new patch ASAP. Keep the same patch, change day, finish the cycle of patches, and start a new cycle of 3 patches with no HFI.
And what's the HFI?
It's hormone-free interval.
Excellent. So it's pretty easy to use the charts, right? And you guys will have it basically these same ones where it's like missed patch, missed POP, missed COC, missed ring, all of those kind of things. So you guys will have a question like that. So that's kind of a gimme question, really, because the answer's right there for you. So to switch back to her actual one, apply a new patch now, and then finish the current cycle of patches and then start a new cycle of patches without an HFI. But for this one, I won't do a select all that apply. I'll just have one answer for you guys. So how about this one? Arranging in most effective to least effective based on typical use.
IUD Marina first, then IUD Paragard, then injection, then implant. Yeah. Most effective is Marina.
It's the implant. It's the third, right?
It's Mirena, Paragard, implant,
Paragard is the copper.
injection,
Yeah.
Nuvaring.
Marina and Paragard is the same. Marina and then Paragard. Oh, implant. Implant, then Paragard. Okay, so implant is the second one. And then
Implant is number 2.
yeah, implant number 2.
It's supposed to be
And then
Mirena,
Paragard's number 3.
implant.
Wait, how you know?
What are you
So
doing?
here,
She will.
Paragard,
2 and 4 are you?
injection, then
So
implant.
what all are you doing?
Injection and then the ring.
Number 2 and 4, 5.
Ring is last.
So number 2 and 5 are IUDs. So they are both they are first.
What?
2 and 5 they are all both IUDs.
One's the hormone IUD, number 2, and one's the copper IUD, number 5.
They're the same,
What's number 2?
they're in the same position.
Like the combined
Implant's
hormone.
better than the copper.
That's what I'm saying, but copper is supposed to follow, right?
Yeah.
But the implant, so
So it's IUD Marina,
implant.
then the implant.
Okay, so what did you guys come up with for this one? I heard good discussion over here.
So we said IUDs first, so copper is probably the most effective, so Paragard, then Marina. And then either implant or injection, and then the intravenousal patch.
So I heard a slightly different but you're close.
Oh yeah, please. Stop. Rose, you wanna talk?
So we put Marina, and then the implant, then Paragard, the injection, and then intravaginal.
So I agree with her answer. The way I kind of think about it is if the IUD also has a hormone on top of it, it's gonna work just a little bit more effective. In general, for the exam, I'm probably not gonna ask you in quite so much detail. I'm gonna ask you the effectiveness, but we're gonna kind of look at knowing the typical use, that the IUDs in general are more effective with typical use than combined oral contraceptives. So kind of knowing IUD, depot, and then the pills kind of down. So knowing just the general, I'm not gonna say like compare the two IUDs and which is more effective. But now you know the answer, so. So they're both actually pretty darn effective, right? And I think I might even have. So, and that's part of why I'm saying I'm not gonna actually ask you that level of a question, because you're starting to basically split hairs. So like the Mirena is with typical use, there's 0.2%, and then Paragard is 0.8% with typical use. So they're just like, I mean, it's negligible. The main thing take home I want you guys to get is basically all the IUDs are pretty high up there as far as efficacy is concerned, and really Depot's pretty high up there as far as efficacy is concerned, because it's hard to forget to take your pill. Whereas the combined oral contraceptives are lower down on the list, and then progestin only is even lower than that. So that's kind of the main general order that I want you guys to understand.
Depends. It could be IA, but you want to be pregnant?
It's IUD.
How about you?
Because she doesn't want to get pregnant for at least 5 years, so it'll be cost effective, and she has no past medical history to be worried about.
So I agree with his answer on that one. So we kind of just had this question, right? So D would be the correct answer on this one.
That way she won't have a cycle.
Yeah, so the correct answer should be A, because of the continuous cycle, you don't experience any types of menses at all.
Exactly. With all the other ones, you're still going to have monthly hormone-free interval where you're going to have that menses type bleed. So.
I don't know if it's 2 or 3 or 1 to 9.
I think it's just 3.
I don't know.
What?
Just 3.
I think it's PS. It's not PMS, it's PS. It's
Oh
PS.
man, no, that's right. It's only one.
Because Libro is only progestin, right?
I think it's only 3. Yeah, you're right. Nothing cures PMS. I think it's 3.
Which one carry PMS?
PMS, it's just not fun, right?
MDD is
I don't know.
Let's get all these pictures.
Why don't you guys walk us through your thought process and I'll help you out. And your colleagues at your table will help you out.
So we know it's 3 for sure that can be used. But we're thinking between if you have a PMS or severe PMS, I think it would work for that too, because Libro is a continuous cycle. So
Do you think all three are different?
yes.
I agree with her as well. So the thing that's a little bit tricky is on the slides, which ones are they indicated for and which ones could you probably really use it for? Because if you're avoiding menorrhagia, so if you're having a lot of extra bleeding at your cycle and you're avoiding having a cycle, you're gonna avoid the issue. So potentially you can use that for that.
It's all the above?
Yeah.
All the three?
So So she kind of gave her reasoning, right? And her reasoning was, hey, if we don't have a period as often, I'm not gonna have PMS as often because I'm extending it out. Is that maybe my first line treatment? Maybe not, but if she already wants to be on a contraceptive, it could actually really help with that. But typically, you might not just give a contraceptive if somebody's having PMS. It depends on how severe their PMS symptoms are. So I like her logic, and that's what I'm agreeing with is, well, hey, if we're avoiding it in the first place, we're kind of taking care of the issue. But I also agree with what you're saying. That's probably not gonna be my first go-to, but a lot of times, women also want contraception during that time period too. So if you can talk to your patient and find out what exactly she's looking for, that could be a good choice for you, or for her. And I think my other question was exactly the same question. What's the drawback to continuous cycle? What do you guys think? So it's kind of a personal preference on it. So some women would say having no menses that's not a problem at all. Some women would say, you know, every now and then I like to have a menses just to ensure that I'm not pregnant. So it's kind of a comfort patient satisfaction level. So reversibility between the continuous and just regular combined oral contraceptives is about the same. So there's not so much difference between those. You're kind of thinking along the right lines though. If you've been on combined oral contraceptives for a long time in general, even with a hormone-free interval, you may have a little bit longer time before you are able to become pregnant again. Or you may be able to become pregnant right away. It could happen either way, so. What about this one? This one's a little harder, right?
COD.
So maybe let's talk a little bit about the USP method. When would you want to use the USP method? So I like her answer, like when you might want to use it. She said,
when cost is a problem, because Plan B is really expensive. Well, any of like the emergency contraceptives are really expensive. And if they already have birth control,
exactly, so she already has it. So she already has it. So that can help if she has a cost issue or she has access to get it. An access issue. That's when we probably want to go ahead and use it.
I think I
Hmm?
2.6.
What's the direction?
Times 3 is 1.45, right?
Hmm?
This has to be 0.5 to
And then which hormone are we looking at when we're
This
going?
is gonna be this hard. I have to do
Levonorgestrel, right?
There's no
And it has to be at that certain level.
because that's the important
Point
hormone.
5 to point 6, right? So then we have to do some math and add up and see what the tablets look like. And how are we gonna do that? We're gonna go and we're gonna look at our formulary that I'm giving you as the exam level attachment. And you're gonna say, or you're just gonna add it because I put it right there in there for you. But you could if I didn't. Probably most of the time, my goal isn't to see if you can use the chart or not. My goal is really to see if you are able to apply the thing. So I'll probably give you the amounts in it, just like that. So his question was the 0.5 and the 0.6, is that each time that you take it? So that's really like the combined overall dose that you're gonna have. So the correct answer on this one is the D.
Good job, guys. Good job, guys.
Wait, why is it D?
You're looking at levonorgestrel.
So
That's what induces the.
So see the levonorgestrel up here has 0.15 milligrams. The levonorgestrel is the component that we're actually keeping track of in the USP method. The other thing that's key, and somebody said it earlier, is if you're using the USP method, technically you can't just use any combined oral contraceptive that you have. You have to use a combined oral contraceptive that has the levonorgestrel. In theory, as a pharmacist, could I probably use one of the other ones? Probably, but there's no studies behind it. Whereas USP's done a whole bunch of studies with the levonorgestrel, so that kind of backs up our plan for that.
Because emergency contraception is progesterone. So just look at
So her question was kind of about, like, she looked at the chart or the formulary chart. My plan as far as that is, because I think Portia wasn't in there, that's okay. My plan is to try and give you guys the strengths up there in the name, like in the question body, so you don't have to go to the chart anyways, because it kind of just slow you down as you're going through the exam in the first place. The chart's there kind of for a backup, but in general you won't have to. And I'll be cautious to use medications that are on the formulary I gave you.
She looks pretty. She's beautiful.
So we kind of talked about this one already.
Was he getting the pictures?
I look at the pictures.
Was he getting?
You guys know the answer at this table?
Is it A? Why you read so fast?
So I know a couple of you guys got it, so I'll let you explain.
So we were saying, with the USEPI method, you have to use levogestrel as the progestin. So this medication doesn't have that, so you can't use it. But if like B is correct, consultation, but just like a general emergency contraceptive.
B.
Good answer, I like that answer.
Answer is B?
No, D.
It's E. Oh, what is E?
B could be right if it was levonorgestrel.
So the correct answer is E. And the main reason that it's E is because it has norgestimate instead of levonorgestrel.
It has to be levonorgestrel.
As part of EC, right?
So this one is not easy?
So levogestrel.
All of these are easy.
Increasing progesterone so that it
And
has
this is for
half
your
a full
regular
period.
control, how you can use it.
purchased.
So the question was, what's the mechanism, because other people have the same question. What's the mechanism of action of levonorgestrel in emergency contraception? What do you guys think? So there's kind of the ways that hormonal contraception works in general, right? So it inhibits ovulation, or sometimes you can delay ovulation or kind of change that time point. It can also change like the pH of the area, and then it can also make the mucus less thicker, so it's harder for the sperm to reach the egg. So it can change the viscosity. And then it can also, those are kind of the main reasons. So for this one, I didn't ask anybody what their answer was yet. But what answer did you guys come up with? So they said C. I agree with C. So the question's a little bit tricky just because of the way it's worded. And they're kind of talking about that progestin only is more effective than the Hughes P method is what they're trying to say with that one. So it's a little bit tricky on that one. In general, to provide clarity to this question is if you were using combined oral contraceptives just regularly, they're a lot more effective at preventing pregnancy than emergency contraception is in general. And then if you were using the Hughes P method for emergency contraception, it's not as effective as progestin only. Does that make sense? Okay, one more time. So if you're just using like daily combined oral contraceptives, that's a lot more effective at prevention of pregnancy than emergency contraception is, right? Just in general. If you use progestin only emergency contraception, that's more effective than the Hughes P method of emergency contraception. So a poor question. But I had already shared it with you guys when I figured out it was a poor question.
In general, just because I don't know, the pH, does it become more basic? You mentioned to the previous question, pH.
Yep, so the pH actually becomes more basic, so it increases the pH instead of reducing the pH. So now what I have is, I just have some general content slides that I reduced down for you guys and was gonna kind of go over what I thought were some of the key points. So we kind of talked about in the veterinary slides, I'm mostly gonna really focus on kind of the key general principles, and the purple text was very helpful. I think the important thing is really what's in purple here. Veterinary patients of different species have different ADME. And in general, you can kind of figure it out as you're thinking about the type of animal and what it eats. If it eats meat, it's gonna have a more acidic gut. If it eats a lot of grass, it's gonna have a more basic gut. And essentially know that there's different metabolic functions and know that there's different renal functions. So for the metabolic pathways, I would say the key things to know again are the purple. Felines have limited hydroxylation, and then cats and ferrets essentially can hardly break down anything because they're obligate carnivores, so they cannot glucuronidate. And kind of again, all the meat eaters have that short, fast gastric time. They have an acidic pH, and with that short, fast gastric time, SR and ER dosage forms are less likely to work. Key thing on this one is the dogs with kind of the squished faces. If you give them respiratory depressants, they're gonna have a hard time breathing. And they already have a hard time breathing in the first place, but since dogs pant to cool, if you gave a dog opiates, which sometimes you need to because they have pain as well, it's gonna decrease their respiration. And if your dog's outside in Fresno in the summer, it's gonna overheat because it can't pant the way it needs to cool off. So same for cats as far as they have acidic guts, shorter guts than humans, and kind of thinking of any topical therapy in cats has potential for systemic therapy because they're groomers. And then I would say this is important to know that they cannot glucuronidate, and acetaminophen and phenazopyridine would be the two drugs to remember for that one. For horses, we talked about how they have that more basic gut and they have really long guts and really high volumes of water that's gonna change their volume of distribution. The other thing is if we kill off their gut microflora, then they can't digest their food and they're gonna starve. And that's the same for rabbits and horses. Cows have a 4-chamber gut. Their stomach does the fermentation. Horses and rabbits are hind gut fermenters. Their cecum does the fermentation. And then there's certain animals that are food producing animals. If we give medication to animals intended for the human food supply, there is a meat withdrawal time and a dairy withdrawal time. I don't actually need you to know this part. You can kind of scratch that part out, but I want you to know if we're giving a cow a medication and we're gonna drink the milk, we need a withdrawal time on the label. And then birds have a different way of breaking down their uric acid than we do, and they have that renal portal elimination system, birds and reptiles do. And on this slide, this just describes the renal portal system. So the menstrual symptom slides were pretty easy. If you guys want me to go through them with you guys, I'm kind of thinking it's probably not necessary for you because they're pretty straightforward. What's the difference between PMS and PMDD? It interrupts your life, so it's really severe symptoms, exactly right. Okay, well, I shall skip through these. And for polycystic ovary syndrome, again, just know the portion that's over here that's kind of describing what the disease state is. And then I do want you to know, like, in general, when you use these medications, that's a key part because we're pharmacists and that's what we do.
Do you give all of those to a PCOS person, or is that what we're trying to do?
So his question was, do you give them all to a person with polycystic ovary syndrome? Potentially, yes, you may be giving multiple medications for that patient because it's a more complex disease state. And that's why I'm kind of glossing over it for you guys right now, is because most of how you're treating it is related to, I guess if I point at the right thing, is kind of related to blood glucose and some of the stuff you guys are gonna really learn from Dr. Nielsen. And then some of it's even a little bit more advanced than that. So we're not gonna focus on it right now other than knowing that it's a metabolic issue that does affect like menstruation or is associated with that. And here's some of the agents you use to treat it. We talked about comparative efficacy and in general about how much I want you guys to know on that. You guys kind of know this piece about contraceptive choices because it really comes down to the factors in contraceptive selection. And I think most of you guys got this on, or were prepared for this on the OSCE. So I'm not gonna spend a whole lot of time on it unless you guys have questions. Here's those mechanism of actions of how hormonal contraceptives work in general. So endometrial lining, cervical mucus, and prevention of ovulation. And then I think it's key to see progestins work here, here, and here. So if you're thinking of emergency contraception, why do we care more about the progestin-only ones? Because it has more mechanisms that it's able to work, especially since it's kind of that shorter time period that we're having it. I'm gonna kind of skip over these pieces. I think you guys kind of have figured out that the red stuff is kind of the stuff that I think is important. So know the red stuff.
Do we have to memorize reversibility for off formulation or comparison versus which one is more reversible?
In general, her question was about the reversibility ones. I would say in general, I want you to kind of know like which major classes are more reversible than others. So kind of a general order versus like the exact days or times or any of that kind of stuff. Just to know, hey, which one's pretty rapidly reversible and which ones hang out a little bit longer. And you probably know some of that already, just by thinking of how often you administer them.
So the slides like generally say don't use use progestin only if you smoke more than 15 cigarettes a day, but the MEC's like more specific. What do we go off of?
So the MEC is more specific, go off the MEC. And in general, part of why the MEC's more specific too is they update the MEC like every 2 years. And then the other reason why the MEC's more specific is there's a couple different types of MECs. The longer MEC that we had that was the more complicated one that I'm not having you guys use, that's kind of used by prescribers in general. And then that Oregon MEC, the simplified one, is for pharmacist prescribing. So if you're not on that Oregon one, you could still probably do it, and different physicians that would still prescribe gynecologists, other folks. But for the protocol for pharmacists to prescribe it, they have us doing a narrower version. Part of that's just as they're getting used to what's safe, what are their comfort level with pharmacists being prescribers. But the MEC is where I would go. So what's important about this chart? Because I keep like throwing this chart up here. Your answer, I'll add.
Just to know which generation has androgenic activity and which generation has progestin and estrogen activity?
Exactly. So when we're kind of picking the agents or we're switching agents, it's important to know that certain of the progestins can have effects or can have symptoms or effects that we think are positive or negative. And it helps us determine, are we looking out for an anti-androgen effect? Or, hey, they're already on a low dose estrogen, but they're still having estrogenic effects. Maybe I shouldn't have norethindrone as the progestin in my combined oral contraceptive. So this chart is key to know. I would mostly know the first, second, third, and fourth or other generations, and I would know the drugs that are in them. And then in general, you can kind of see, okay, this one has effects across all three. This one, we lose some of our estrogen effect, but we still have a high progestin and androgen effect. And then the third generation, we still have a little bit here. And then these ones are the anti-androgen. That's kind of the key that I would know. Don't memorize the number of pluses and the number of minuses. Just have a general philosophy for how they work and know which drugs are in which ones. And then when do we use progestin-only pills? Again, you can really use the MEC, like she was saying. That's an easy way. But this kind of helps you as a pharmacist in practice. You can kind of skim down and know the answers to the questions without even going to the MEC sometimes. And then on the ones you're like, oh wait, I don't remember lupus, let me go check that one up, it's not that common. So then I would use the MEC in that kind of situation. So I guess I wanted to remind you guys to know how to use the MEC. Hopefully you guys all do. Contraindications essentially are all outlined on the MEC. And it's all pretty much clot related, so it's pretty easy. And kind of know the red spots on this clotting one. The stuff for drug-drug interactions, that's gonna be kind of key for all the contents sets that I have. And remember, we wanna actually use higher levels of ethinyl estradiol when we know we have a drug-drug interaction that's decreasing it. And then it would be good to know which anticonvulsants do not increase steroid levels, or do not decrease rather. In theory, you probably only have to memorize one of the charts and then just be like, oh, it's not on the one that I remember. And then kind of the general things about efficacy is just having that general ranking of where things lie. You guys should all know about the START methods, so I'm not gonna spend time on that. I think you all know about new starter effects and the increased breakthrough bleeding. And then this is a key slide. I can pretty much promise I'll have a question related to that. And then this kind of just walks you through, so it's kind of nice because you can chop out a whole bunch of other things and it's all just listed right here. And I feel like we talked a lot about emergency contraception with the case questions. I think the key thing, this slide kind of summarizes that whole presentation into one slide, so that's kind of why I like this slide. And then you just add a little bit about what do I use to treat, what antiemetics do I use, and you've kind of got that whole presentation down. So metoclopramide or maclazine. And then I have one more slide set for all the other stuff. Is this helpful? Because it's kind of optional. If you guys leave, I'm not going to be offended. Because I'm just reviewing the main content that already exists. You guys have already seen. So, drug-induced, that's pretty much, I'm always going to ask questions related to drug-induced and drug-drug interactions. So, I'm not really going to go in detail on the slide because it's pretty straightforward unless you have questions on it. I'm just kind of re-emphasizing some of the stuff I'm going to talk about. And what's the process if we're going to manage a drug interaction? What are we going to do? Like, so I have peptic ulcer disease. I'm going to use a different H2 blocker or a PPI. This one's kind of nice because it basically walks you through everything, and you could just draw some little lines off here with some specific details. But of course, the drugs are going to be a big piece of what I'm going to talk to you guys about. We talked a little bit about the mechanism of action. In general, I'm not going to ask you guys tons of mechanism of action type questions, but if you know the mechanism of action, you kind of know everything about the medication and you know when we're going to use it. So I think this is nice just because it's a comparison of the different agents and the adverse drug reactions, which are also patient counseling points. So again, here's some more of the patient counseling points. And then the key thing on this slide is, okay, well, if I have to pick between agents, how am I gonna pick between agents? So if a patient has poor creatinine clearance or is over 65 years old, are there certain agents I'm gonna avoid? Or is the patient, my counseling points related to food? Those are key things to know because they're in the same family, but they are a little bit different based on the chemical structures. And then I think the key one is orthostatic hypertension with alcohol. Typically the ED medications, people like to go out for dinner and have a drink and get romantic. So there tends to be a combination in those kind of things. More counseling information. I want you to be able to understand how you use these different agents. And then I think the key thing for the testosterone replacement, don't over-memorize the hormone levels. I just want you to know there's a really wide range in healthy males. So you may, if you tested a testosterone level in a man that's feeling like he's less energy, not the same muscle mass, and he's at 500, yeah, he's still in the normal range. But if he was at 1,000 when he was in his 20s, he's gonna feel significantly different. And then counseling based off the different dosage forms, that's a key one. Probably I'll have a question on that. Because the thing about this with the testosterone replacement agents, it's also the same as a lot of the hormone replacement agents. They're the same type of dosage form, and kind of knowing the things related to the dosage forms is gonna apply regardless of the medication. In general, for the liver function for this exam, is I would just say, do they have, you don't have to know the limit per se, but is it this patient, I'm gonna kind of give extremes. So does this patient have really severe liver failure and cirrhosis? Which agent would you choose? So I'm not gonna give you a lab value that you're gonna have to interpret and determine if they're, does that answer your question? Because sometimes it's 3 and 2. In general, for those, like as a pharmacist, I'm just gonna be like, this is a red flag, I'm gonna go double check. Because you have enough other things to like keep in your brain that you can always look that up. And then of course, anytime there's kind of the flow charts talking about how to use them, I think those are really helpful. And then just like the factors used in determining a contraceptive, the factors used in determining a specific ED treatment, it all goes back to the pharmacist patient care process that I talk about over and over and over again. It's kind of that same process for all the medications, so you can kind of guess what's gonna be key. And signs and symptoms of hypogonadism, that's key. And then the drug-induced again. Definition of menopause, what it is, the 12 consecutive months, that's key to know. Which hormones important in perimenopause? Progesterone. And the reason progesterone's the one that's important is you start having those anovulatory cycles, right? And if the corpus luteum doesn't rupture, it doesn't make any progesterone. And then when you don't have any progesterone, then you kind of have this erratic cycle. And during that perimenopause, sometimes you can become pregnant, sometimes you can't, and you're not really 100% sure. So basically the signs and symptoms of perimenopause and menopause are gonna look pretty similar. And then menopause is after you've had no menstrual bleed for 12 months in a row. So it's really those hot flashy symptoms, night sweat symptoms are kind of gonna be one of the ones that patients really report the most, but they're gonna talk about sleep disturbances, mood changes, and then these other ones show up as well, but typically their chief complaints more either hot flashes or sleep, mood, focus, attention. And then the Women's Health International. What was that one? Do you guys remember? There's kind of a bunch of slides on it, but you can kind of summarize that down to, okay, for Women's Health International, they just looked at conjugated equine estrogen and medroxyprogesterone, and then they said, you know what, this can cause some issues. Let's only use it as short of a period as possible, and just for symptom relief. And then they kind of came up with some advice that just made sense to begin with. So the yearly mammograms, avoid risk factors for cardiovascular disease. And you still want to do some additional type of osteoporosis prevention. So know about vaginal atrophy and urogenital symptoms. This also kind of overlaps a little bit into our incontinence material. I think this is a key slide for you guys to know because it kind of summarizes the different options that are out there. And then I think there's about 5 or 6 slides on SERMs. Know about each of the SERMs. And know what bioidentical hormone therapy is.
What regimen did you say is the best to continue?
So so her question is, which one of these is the best? So it kind of is somewhat dependent, but most women are gonna like the continuous one, like you said, because they're gonna have that amenorrhea, or they're gonna not have the menstrual bleed anymore. So they're seeing that as a positive thing, because when you're 65, I don't really want, probably don't want to still have your menstrual bleed. So you guys remember bioidentical hormones means it's the same exact chemical structure that's normally found in the human body. So the only ones that are actually bioidentical for estrogens are estrone, estradiol, and estriol. So I'd say this is a good slide to know. And if you get them compounded, they typically do them in a triest and a biased combination. The biased is more commonly used because it doesn't have estrone. Estrone's the estrogen most associated with breast cancer. There's a whole metabolic pathway about showing why it is, but you guys don't want to memorize that. And I don't have it memorized either. And then I think you guys get a general feel. How about I just turn the rest open for questions instead of converting through here, because I'm just kind of saying that the same kind of things. If it's know the signs and symptoms of the condition, so like hyperthyroid, hypothyroid, Addison's, Cushing, know the signs and symptoms, know what causes drug-induced, know what the treatments are, know if there's drug-drug interactions. It's kind of the same types of things that I'm asking on them. But then it leaves more time for you guys to ask general questions or one-on-one questions. Yeah, I'll post these compiled ones for you guys. The key thing, like I said, is there's probably still going to be some stuff on a few slides that aren't on here, but for a quick review, I'll post it for you guys.
On the contraceptives, when it says take like your question, it said take 4 right now, take 4 12 hours later. So you take 2 doses, as soon as 8 in the morning and 8 at night. What does that mean the following day? Is it after 12 hours?
So the main thing with the 12 hours is if you did it all at once, you're gonna have a really high nausea type symptom and you're gonna throw it up. Because as you take more of that estradiol, you're getting that upset GI stomach issue, and that's why you do the antiemetics with them. So if you took it all at once, you'd probably throw it up every time.
And for eventually legal progesterone, the 26, so each dose not the whole day, if you were taking 8 in the morning, 8 at night, that would be 2 milligrams.
Correct, so it's 0.6 total for the day.
No, for the day that's because you did 4 right now, 4 later. 15 times 4 is 0.6.
Well, we'll double check on that one. I don't remember now. I have to look, but.
4 in the morning and 4 at 12 hours. Right. So it's supposed to be for the whole day, like 0.6.
So it should be 2.
The use P method. Use P method.
No, I think you do it.
Use P method.
I have to double check because I don't remember either. But essentially, I know it is 4 pills each time. So therefore, in my logic, but we could double check my logic, is that it's the 0.6 with each dose instead of the daily dose. But I do know typically with the USP method, it's 4 pills at a time. It's not just 2 at a time. So I can send an email, and you guys can also look, right? Because you're pharmacists too. So that would work as well, right? So that's actually what I'm going to encourage you to do is look. You're welcome to share the answer with your colleagues, or send it to me and say, here's what I found, can you share this back out? But that's what your preceptors are going to do for you too. Like, I don't know, that's a good question, why don't you get back to me with that one?
That's true.
She already found that. So.
And it says, so it is the 0.5 to 0.6 milligrams, but it says 2 doses 12 hours apart. So when they're telling you the slide, you do 4 tablets now, which would be 0.6, and then another 12 hours, you're gonna take 0.6 again.
So you're doubling the dose.
According to like the slide, you're taking 0.5 and 0.6 at one time, and then 12 hours later, you're gonna do 0.6 again. So that his question does make sense, that if you take 4 tablets now, you're at 0.6. 12 hours later, you're gonna do 0.6 again.
When you first give estrogen, they're low, EP, and then progesterone.
Per dose, not per day. Exactly. And I can verify that from what I've done in practice. In practice, we didn't have Plan B when I first was a pharmacist. We were doing the 4 per dose.
It's not by time, that's something different. Read through
I think
it.
I wrote all of the charts down that you will be providing. Are they all in this PowerPoint?
They aren't, but I'll re-say them. So the charts that I will be providing are the MEC, the contraceptive formulary, the missed dose charts, and you'll get the questionnaire, because you kind of need the questionnaire. Granted, with the MEC, you could kind of figure out the questionnaire without it, but I'm gonna actually have a sample filled out questionnaire, just like you guys did for the OSCE. I think that's it. Was there another one you guys think that I should be providing?
How many questions? It's for
So it's 3 questions per topic day. So here, let me pull up the syllabus. Because that's actually a good question, because there's a couple days that aren't real topic days, right? So hold on just a second while I pull it up.
Yeah. So if they have side effects, you give them estrogen first, early. If
they have side effects early in their cycle,
then you give them estrogen.
then you give increased estrogen.
Yeah.
But if they late,
Yeah.
what do you do?
Progestin.
You increase the dose.
Progestin, yeah.
You don't just give it. You increase the
Yeah, increase the dose. Oh.
Does that make sense?
Yeah, makes sense.
And then if they're having bleeding mid-cycle, you
Both more.
increase the dose.
Tomorrow's the day off, right?
Yeah.